Thyroid cancer has become an increasing problem throughout the world. The incidence is rising by leaps and bounds, nearly 200% increase in the United States over the last 20 years, and similar rise in many other parts of the world, including Russia. The exact cause of this is not known, although I think we attribute this to overdiagnosis, overuse of technology, increasing awareness, and over-enthusiastic physicians and endocrinologists. Liberal use of ultrasound. Even a general practitioner, just for the heck of it, would say, go get an ultrasound of the neck, and then you find a small nodule. Fortunately, a great majority of these incidentally found thyroid cancers are relatively innocuous cancers, easily curable. Cure rate is nearly 100%, and they are not a threat to life. The flip side of the coin is there are some patients who will have a more advanced or aggressive thyroid cancer, which can be lethal. So the use of technology is appropriate, but the interpretation of what we see by early diagnosis requires some restraint. Thyroid cancers less than a centimeter in diameter can be easily left alone. There is a huge experience out of Japan by the group of Miyauchi and Ito, who have followed sub-centimeter thyroid cancers for years with a very small conversion rate requiring surgery. We have an ongoing trial of observation at New York. Over 200 patients now followed for over 5 years, and 5 out of 200 had to undergo surgery because of slight increase in the size of the nodule. So I think many of these can be relatively innocuous and can be left alone. We simply follow the patient. Sometimes we hold restraint in even doing a needle biopsy, because once you biopsy and have a diagnosis of cancer, the anxiety in patient's mind starts, and she is looking for a surgeon who will operate. So the message we want to convey to the medical audience at large is that be sensitive to overuse of technology, not make the patient and the family apprehensive for a relatively innocuous problem. Remember, the autopsy incidence of thyroid cancer is somewhere around 10%. And that means these folks lived their whole life and died of something else, where a papillary cancer was found at autopsy, which never came to life. So I think knowledge of the biology of the disease is more important than putting your hands in gear to operate. It does, but I think the metastases generally occur to lymph nodes in the neck and in the young patient. And when I use the word young, under 50, the implication of metastatic disease in worsening prognosis is nearly zero. Yes, they do metastasize, but they don't die from this disease. Because of the patient's anxiety, I would do the first, let's say we found a 6 millimeter nodule in the thyroid gland, looks suspicious, you want to restrain. For patients' apprehension and to allay the anxiety, you may repeat the ultrasound in 6 months. Nothing's going to happen, but patient will not feel that you are abandoning the patient. If the nodule is stable at 6 months, I would say come back and see me in a year. Repeat the ultrasound in a year. If the nodule is stable, I would go 2 years. And 4 or 5 years, if the nodule is stable, forget it. There is also a notion that every thyroid cancer needs to be treated the same, that everybody needs a total thyroidectomy and radioactive iodine treatment. That is gross overtreatment for a majority of patients who fall into the low risk category. And if they have a single nodule which is within the thyroid gland, a lobectomy alone should be curative. There is no need to remove the whole thyroid gland. There is no need for radioiodine treatment. So you reduce morbidity, reduce cost, and deliver cost-effective treatment without the complications or sequelae of treatment.